Hey, welcome to Alabama EMS Challenge. Good morning, everybody. Thank you for being here, for those of you here in person, and thanks for all of you joining online. Today we've got
Guys, good
Dr.
morning.
Paul Kirby and Dr. Tyler Sullivan, and we're about to get started with Dr. Kirby.
We're good to go. Yeah, you hear me? I think last time I was here, I started and there was no sound. Like the first 10 minutes, so I had to start over. So I was here a couple months ago. My name's Paul Kirby. I'm one of the EMS fellows with Tyler. Today we're talking about cases in resuscitation. And what I did is I actually went and looked at all the cases I had saved over the past 3 or 4 years in the hospital, specifically over the first couple years of residency. And I looked at the complicated cases and how they would apply to you guys. And so I have 6 cases here, which are pretty interesting. I'd like to go over. I've tried to block out like any identifying factors, but please, this stays in between us. All right. So the first case, if you can imagine, EMS was dispatched on a mid-50s, 60s female for 1 week of slurred speech, facial droop. Vitals were okay, D-stick was okay, and they were brought to the UAB launch pad, which is an area where we evaluate for all strokes. By the time the patient got there, she had no deficits at all, nothing at all. But then the daughter called and spoke to one of the nurses, and she apparently called EMS because she was having left-sided weakness. Again, we didn't have that there. And when we were evaluating, patient was drowsy and confused. What does this sound like to you guys? Do y'all know? Any idea? Yeah, like a TIA. Infection too, if you listen to my geriatric talk, I said any type of altered would be infection. Deer camp? Yeah, spent too much time hunting. New medication, yeah. But this to me would be more like a TIA. So they had some weakness, daughter saw some weakness, and that has resolved. So transient ischemic attack. So this was my HPI of what I said as soon as I evaluated the patient. She had a past medical history of COPD, hypertension, migraines, presented to the emergency department for concerns of stroke. By the time she got there, her deficits had resolved. She had no infectious symptoms, but had been around like a flu-like illness recently. So maybe a TIA, maybe an infection. So whenever a stroke patient comes to the emergency department, it's important that we do a quick exam. So I need a volunteer. It's all right. It's all right. So there's 2 different like neuro exams that we'll do. First, I wanted to kind of briefly talk about the complete neuro exam. So I just walk up. He had a normal gait. He wasn't stumbling, and that's part of it as well. The first cranial, yeah, you're gonna get me in trouble this morning. The first cranial nerve, okay, is the olfactory nerve. So this is where you smell. And I'm gonna keep it appropriate, but you could ask him to smell like coffee or something. Not, yeah, exactly. I'm glad someone said it. The second optic nerve would be your second cranial nerve is your optic nerve. So I just have him look in the wall and see like, what do you see? Just basically see if looking normally. The third one would be ocular motor. And so for this one, I would be shining a bright light in his eye, looking to make sure his pupils are responsive, and that's also part of your eye movement. Your fourth cranial nerve, your trochlear nerve, is your eye movement as well. Fifth is going to be your trigeminal nerve, and so this is what like your masters bite down. So I'd have him bite down, clinch. Gets it. I heard it. I heard it. So he's good. Sixth nerve is the abducens. So this is a lateral eye movement. So I'd have him like look straight ahead and then look over here to my finger and then look over here. Okay, so he's able to move back and forth. 6 nerves intact. His seventh would be his facial nerve. And so this is where I would go up to the patient and I would touch here. Do you feel that? Same on both sides? You better say yes. And then I would go all the way down around the cheeks and the jaw. Does it feel the same? Good. The eighth is your vestibular cochlear nerve. So this is your hearing and balance. And so as I said, he walked up to me and I saw his balance was okay. And then the way you're supposed to test this, if you look at videos, you're supposed to like make sure that he hears both sides and he's able to repeat those. Again, I'm going to keep it appropriate. Your ninth and 10th, your glossopharyngeal and your vagus nerves, this is like your gag reflex. It's really hard. I'm struggling here, but you would stick like a tongue depressor in the back of your throat, make sure that the uvula is midline, Make sure that the soft palate is balanced on both sides. And then for your, let's see, 11th is your accessory nerve, which is kind of your shrugging. So I'd put my hands here and have them shrug. And then your 12th would be your tongue. So stick out your tongue for me. Make sure his tongue is midline. It's not deviated one way or the other. That takes a long time, right? I don't have time to do that in the emergency department. You guys don't have time to do that. So typically what I like to do is if they're on the stretcher, if they're standing up, I have them hold your arms like this. And I go pull down, push up. It's equal on both sides. I have them hold their arms out straight, palms up, close your eyes, and I count to 10. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good. All right, you can open up. I have them like lift legs. Ideally, they're on a stretcher, so I'm going to have them hold one leg up, count to 10, make sure they can hold it up, do the other leg, count to 10, hold it up. The problem becomes is if I have them do this and I close their eyes and I start count to 10 and they start drifting off like this, right? That's pronator drift. So they had drift on this side. And then I would expect if I held their leg up for 10 seconds, it would start dropping as well. There'd be weakness on this left side. So that would be my focus exam there. I'm starting to feel like, do you feel this? Same on both sides. Feel this? Same on both sides, all the way up and down. So sensations intact bilaterally. I like to do the whole face thing. Feel that, feel that, feel that. Stick out your tongue for me. Smile. Good. Pretty smile. I like to tell people it's a pretty smile. Usually it's a intense situation, so I want to make sure to lighten it up just a little bit. You can have them say things like, it's a sunny day in Springville. So there's no slurred speech there, so I think he's all right. I don't know. We might have to do that again here in a little bit. And finally, if they're dizzy, if they're complaining of dizziness at all, I like to make sure I get them up and walk them. Okay, so you can have them first stand with your feet together. All right, hands by your side, look straight at me. All right, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. So he's okay there. Close your eyes now. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good. All right, now can you walk heel to shin for me? It's like I'm doing a sobriety test right now. Good. Balance is good, and then I'd have him just walk normally, come back. So I've got him up and walk him. If he has like a posterior stroke or something like that, he won't be able to do that. Something will be off, okay? And I didn't really get into that. All right, we're good. I'm done torturing you. So there's a difference between your complete neuro exam and then your focus neuro exam. So I did a focus neuro exam on this patient. Oh, this is your IMSA score. So again, anything greater than 4 is probably a LVO. But kind of goes through exactly what we talked about, like you're assessing your horizontal gaze, right, which would be your 6th nerve, your facial weakness, arm weakness, leg weakness, ask them if they can name something, you can have them repeat something. But this takes less than a minute to evaluate. The reason we're doing this and the reason we're doing it so quickly and we're only doing a couple of these cranial nerves in this assessment is because we're trying to localize where the stroke would be. And so the big parts would be your MCA and your ACA, which would be your contralateral weakness. So if they're weak on the left, I would worry about an MCA on the right and vice versa. Your apica would be your posterior strokes, your ataxia, your dizziness. And so that's why we assess those and we get our patients up and we walk them. And then there's all kinds of things here that get a little more specific than what we're going to be assessing for, but we're trying to look for large vessel occlusions when we're doing this focused exam. This is our NIH score. So this gets into a little more depth and we start assessing more things here just to evaluate how bad this is in order to see if they're within the window. Are we going to lyse them? Are we going to do a thrombectomy? Again, it's yeah, that's a great question. It's more like lytics. So if you can imagine they've had an ischemic stroke and they have a blood clot blocking this area of the brain and blood flow. So lysing or lytics would be going in and just essentially dissolving that blood clot. Does that make sense? Thrombectomy is where you would go in and you would pull out that clot. So mechanically. Yes, yeah. But there are risks with the clot buster, such as bleeding. So we'll kind of get into that here in a little bit. So again, I'm doing this exam. I'm looking for focal deficits, keeping in mind the patient's last well known, because again, we're going to maybe, if they have a high enough NIH score, they have these deficits, it's within the 4-hour window or so, we're going to probably give them lytics. if you give them lytics and it's a large vessel occlusion, they can still go for thrombectomy where they pull it out. Or if they're outside of the 24-hour window, there's probably nothing to do but optimize them on medications to make sure this doesn't get work, and some physical therapy as well. All right, so this was my physical exam I documented on this case that we had of the patient that came in with some weakness. Okay, she's obviously weak globally, but no focal deficits. She has her sensation intact. She had no pronator drift, no facial droop, no tongue deviation. Okay, so she's globally weak. I don't know if that's her baseline or if, again, this is infection. Regardless, she was sent to us for the evaluation of a stroke, and it was a TIA. And as a, I guess, young physician, this felt bad for me not to call a stroke. And luckily, it was early in the morning. I said, let's go ahead and get the stroke imaging quickly. But I don't think this is a stroke. So she went to the launch pad. We got the CT scans, and we ended up getting the CT scans. This was my MDM that I put. I said, sent for concerns of stroke, no focal deficits. We did not call it, but we did get prompt CT imaging. She had a history of an aneurysm, a brain aneurysm, and repair and clip. So I got angios to look for any evidence of a bleed. Her glucose was normal. Again, I was looking for any metabolic infectious causes of the patient's weakness. Workup was relatively unremarkable. Her magnesium was low, but that wouldn't cause anything. EKG was fine. COVID, flu, RSV was negative. So finally, I think family was at bedside, and I was able to talk to them about it. And they said that around noon, she had left-sided weakness and slurred speech. But again, by the time she got to me, it had all resolved. This was the initial CT scan that I got. No acute intracranial abnormality, no occlusion, no flow-limiting stenosis. She had an aneurysm in the right ICA, okay, that had a clip, which is very important because we talked about lysing someone or giving lytics. Usually if they have a clip or an aneurysm, you want to hold off on this because they have a higher risk of bleeding. So yeah, these would be absolute contraindications to giving them this medication that's going to cause them to bleed, and one of them would be known AV malformations, and these would be relative contraindications. I just realized I'm gonna go a lot longer than an hour, so I'm making up for last week for sure. So this is where it kind of takes a turn for me, and this was this is a very cool case, but at around 5:20, I got a call from nursing staff where they came to me and said, hey, family says that patient has changed. Do you mind coming and evaluate? And I am a firm believer that if anyone comes and grabs me, I'm going to go to the patient immediately. So I went over there. And on my reevaluation, she's able to look in all directions. However, she's complaining of left arm numbness and weakness. And now she has 1 out of 5 strength on this left side. So I reached out to neurology because I was like, hey, this is like an evolving exam, but I have this normal CT scan, and then like I'm literally on the phone with neurology, and I look at the patient, and now she's not looking to the left, so she's having left neglect too. So she's only looking to the right. And I'm like, I'm calling a stroke. So I called a stroke at this point. So patient had been in the hospital. I said, wasn't a stroke, got normal CT scans. The exam changed on me right in front of me, and then I called a stroke. This was her CT scan. And the reason I wanted to show you guys this is that little bright area in the middle of the brain, or on the, I guess, right side of the brain, is her clip. So she had an aneurysm there, and she had a clip placed. This played an important role because this clip is probably blocking where this thrombus is. So because there's so much artifact from this piece of metal, you can't see where that blockage is. And so the repeat CT scans, if you look down at the perfusion at the bottom, there was suspected developing ischemia in the right MCA vascular distribution involving the right parietal and temporal lobe. So she was having a stroke right before my eyes. Ultimately, this was such an interesting case. The neurology attending actually came down and talked to us, and we had a long conversation with patient and family about this. Because she had the clipping, there was risk of giving her the lytics. However, there was some data, and we went through it all, that because of the timeline of things, it was still okay to give it to her. So we ended up giving her lytics. She was admitted to the NICU. She ended up being discharged not too long after on medications, and she still has some left-sided deficits, but they have improved with physical therapy over time. So I think the big summary for this first case was, one, for you guys, TIA is a flag for something bad. And this was a good reminder for me, because a lot of times patient comes in with complaint of weakness, and by the time I evaluate them, it's gone. If they're not optimized on medications already, this needs to be a red flag, because they're at a higher risk for a stroke later down the line. And I saw this firsthand. And oftentimes you are the only group of people that are going to see these deficits, right? Because you'll see them in the field. They'll have these deficits, and they'll come to me or someone, and we'll look at you like it's crazy, but you have to report this to us because this is important information. I had a case not too long ago of a patient that came in early in the morning. It was a young patient, had some right-sided deficits that started the night before, had ended up reaching out to 911, and a company came out, evaluated her, and told her to sleep it off. So I want to let you know that if you do a focused exam and you have any type of deficits, please bring this patient in. Okay, even if it's a TIA. Again, we just talked about how it's a sign for something bad. One of the other things I wanted to hit on while on this case is hypertension is the #1 modifiable stroke risk factor, but it's not necessarily, an acute cause of a stroke. And what I mean by that is there is no technical stroke level of blood pressure. So you'll hear patients being like, I call 911 because my blood pressure is high, and that's stroke level, or I've been told it's stroke level. That's no such thing. It is a modifiable risk factor. If you have history of high blood pressure over a long time, it increases your risk for stroke, but just an acute change isn't necessarily going to be a stroke. In fact, there's, I think this is our governing body in the emergency department, for asymptomatic elevated BP or asymptomatic markedly elevated BP, there's evidence that we're not going to give them medications. We're going to give them home medications or restart their home medications and watch. So asymptomatic meaning they're not having chest pain, they're not like altered, things like that. Make sense? Cool. Any questions about that first case? Cool. All right, case 2. Gotta remind this one. So this is an older gentleman that came in, history of CAD. He was on aspirin, hypertension, presented for altered mental status. And I'm going through these notes, and there's so many typos. It's unbelievable. It's because I'm speaking in Dragon. But this patient woke up in normal health around noon, started having the worst headache of his life, and then became more altered. But essentially he became altered and then got better and then became more altered, was able to even walk to the car or ambulance, I think. So interesting case. What does worst headache of your life make you think? Anyone know? Brain bleed. Worst headache of your life, brain bleed, the subarachnoid hemorrhage. And so I did a physical exam on him. His vitals are okay. Blood pressure's a little high. But other than that, he was neuro intact. Nothing to really explain what was going on. He's afebrile. Don't think sepsis necessarily. So again, worst headache of your life, you're thinking subarachnoid hemorrhage, but these are the differences in the epidural hematoma and subdural hematoma. What I wanted to mention here is that worst headache of your life is subarachnoid hemorrhage, but the lucid interval in which someone like hits their head and they're awake and then all of a sudden they're like completely out of it, that would be what we call a lucid interval, would be an epidural hematoma. Typically patients hit around the temporal bone and this middle meningeal artery is busted. So that would be more associated with your lucid interval, but you can have that in other brain bleeds like your subdural or your subarachnoid. So this patient almost had what I thought was a lucid interval too. So it wasn't really fitting both, but I still thought maybe subarachnoid. And again, your subarachnoid is going to be from an aneurysm down in the bottom of the skull and kind of bleed around like the inner parts of the brain, not necessarily the outside. So I'm thinking that this patient might have had a subarachnoid hemorrhage and had a lucid interval with that. So we wanted to get a CT scan pretty quickly. And this was the CT scan. Y'all know what this is? It's bad. It's a subdural hematoma. This is not a subarachnoid or an epidural hematoma. So this was a subdural hematoma. I have no clue if he fell, no clue or whatever. If you see here, this ventricle is completely gone on this right side and everything is kind of shifted over. So this would be a significant subdural hematoma. Again, extension, pushing over to the right. There was no herniation at the time. You can kind of see that there. So for like, and now in this case, it was kind of unclear, did he fall or was this spontaneous? And when you see a subdural, you kind of think that the patient might have fallen and ruptured one of those bridging veins and caused some bleed there. And so at UAB, we have what's called a big scoring system. You would think that a brain bleed like that would cause automatic like admission, all these things, consults, but this is just to show that if you have a small subdural, so on the left would be our big ones, which would be like the less clinically significant ones. But if they had a small subdural hematoma, they weren't intoxicated, they weren't on any aspirin, Plavix, or anything like that, we actually are not consulting neurosurgery. We're not repeating a head CT. We're going to watch them for 6 hours. And as long as they remain okay, we'll probably discharge them home and have them follow up. The problem is that when you start getting bigger in sizes, you start having more than one, like a subdural, epidural, things like that. Then you start getting into badness. So you're consulting neurosurgery, you're consulting neurology, and you're repeating head CTs. Cushing's triad is something you need to look out for, especially an old person hits their head and they have some bleeding. They're at risk for herniation to where that pressure in the head starts pushing down. You start herniating downwards. And so when that happens, you'll have bradycardia, hypertension, and irregular respirations, which really doesn't make too much sense. You would think that it would be the opposite. So that's why you keep this where it's at. So we consulted neurosurgery. He ended up having a right craniotomy for evacuation of this subdural hematoma. We ended up having to intubate him, and so we consulted them. They did a right craniotomy, and I wanted to put pictures here, but it's a little gruesome. You cut the skin around the skull and you lift it. You drill a hole to relieve some of that pressure first, and then you cut out the skull itself. And I believe what they do is they put a little protective barrier over, sew it back up. They let all that pressure and swelling get better over the next couple of days, and then they put like an artificial covering there. I'm no neurosurgeon, but that's what I was reading about last night. So it was pretty interesting. So my summary for this case was keeping the differential broad and know the protocols. So this guy came in altered and he had gotten better. So I did everything I was supposed to, but I was leaning towards subarachnoid and he ended up falling. And so this patient also ended up doing pretty well, I believe. He did have a seizure while he was intubated after, so he got neurology on board. I think he's on Keppra lifelong, but now I think he was doing well last I checked. Which one's this one? We're getting into a couple of cool trauma cases here. So this one was a level 1 that was by ground following an MVC. Came in, airway was intact, bilateral breath sounds, had femoral pulses, GCS was 15. Was endorsing C and T spine tenderness, no L spine tenderness. And the big part here was that the patient was not moving her lower extremity at all. Sensation was actually absent below T10. So you ask, where's T10? T10 would be around your belly button. So she could not feel from her belly button down. T4 is around your nipple line. So T4, T10, those are kind of where we try to estimate where things are at. So below her belly button down, she could not feel anything. And so I wanted to talk about this a little bit too, because last week we talked about cervical collars and log roll and everything. If a patient has a deficit like this in the field, so they're not able to feel, not able to move, this is when we're doing full spinal motion restriction. So log roll, backboard, cervical collar. What's difficult for you guys is sometimes you're in a 2-3 person crew, maybe even one at some volunteer stations. So it's hard to do this by yourself, but you really want to make sure that you do it correctly. The picture of this person here holding, like giving cervical spine support just by holding the head, I've never liked that too much because the head weighs a little bit more than what you think. And I've seen people just holding by the ears and they roll and then all of a sudden that head drops just because they're not supporting it. What I like to do actually is I like to take my hands and almost pinch their traps and then pinch their head in between my arms. And then just kind of hold that there so when they rotate, I rotate with them and keep their head in between. That makes sense? just because I myself have grabbed a head and it's been heavy and it's moved a little bit more than what I wanted. So for a patient like this, you're going to log roll. I don't know if y'all can see that very well. No, this one's fine. Yeah, GCS fine, physical exam's fine, except can't move lower extremities, can't feel below T10. And she has C-spine tenderness, T-spine tenderness. So there's different spinal cord injuries you can have. One of the ones I wanted to mention was the central cord syndrome. This is where you like hyperextend the neck and you'll have cape-like distribution of symptoms. So their upper extremity will be weaker than their lower extremity. You would think central cord here. You could also have anterior cord, which would be the opposite mechanism of flexion or crush. And this would be complete loss of pain and temperature below the lesion, loss of motor below the lesion, but you would still have position and vibratory function. This is getting very complicated, but you need some different tools to assess some of this. Again, we talked about cervical collar last week in the geriatric population and backboard, and I was asked, do we need to do this on every patient and blah, blah, blah. This was a statement released by NAEMSP, spinal motion restriction following blunt trauma. So if they have an altered level of consciousness, if they had midline neck or back pain or tenderness at all, if they have focal neurological signs or symptoms, if they have an anatomic deformity of spine, so if you press on the spine and there's obviously something wrong there, or if they have distracting injury, and this is a big one. So if they have like a broken femur and they're in pain there, a broken arm, they have a distracting injury from their back, then you probably need to put them in a C-collar and consider backboard. Can't remember. Sorry. I think that's actually from your state protocols. I think this is state Alabama protocols for spinal injury. And again, it kind of just goes over the same thing, but the big one here is the physical exam. And if they have any type of neurological deficits, put them on a backboard and cervical collar. You could also do Canadian C-spine is what we do in the hospital. So when deciding to put them on a cervical collar, what you do is you palpate. One, they have to be less than 65. It has to be a low risk mechanism. Palpate down the back of their neck in their cervical spine and ask them to look left, right, up, down, side to side. If they have no pain in the midline of the neck, they're less than 65 and it was a low mechanism, probably don't need to put a collar on. Any questions on that one? So this patient, we got all the trauma scans. She had acute C6-7 injury and a bunch of fractures. She had like a pneumothorax on both sides, I believe, a hepatic injury, pelvic fractures. But the big one here was the cervical spine injury. Y'all see it? No, it doesn't look good. So I think I've walked through these before, but you're essentially looking to make sure it all lines up, right? You're making sure the cervical spine lines up and then the posterior components. And obviously there's something wrong here. It shouldn't be zigzagging like that. So she had an injury. One of the complicating things here is that there's different services that cover spine for us. And so I think orthopedics was covering for spine that day. I think neurosurgery was covering for, she had like a vascular injury in the neck, which neurosurgery covers. Neurosurgery wanted aspirin, but obviously ortho is going to go operate on this neck because it's a pretty severe and unstable fracture. And so we had to communicate between the two and balance. We had to play the middleman as far as how are we best going to do this. Ultimately, aspirin was okay. She was taken to the OR. Taken to the OR, had MAP management, and maintained C-spine precautions. So for the big thing for you guys is physical exam, spinal motion restrictions. If the patient's intoxicated, distracted, injuries, or high level suspicion, just do everything for them. Any questions? Cool. I'm doing all right. This was one of the patients that I probably thought the most about in residency, but this was a trauma that came in after a boating accident. When they arrived to us, it was a transfer from an outside hospital. Patient was already intubated, I think had a right chest tube, but they were sent. It was a transfer for like facial fractures. Nothing any crazy too. They just needed face. So facial fractures after a boating accident. They're intubated. This was our physical exam. Anybody see anything wrong with the physical exam? This was the one that something was wrong with. As the senior that was signing this note, I should have caught this. GCS was not 15. They're intubated, so it would have been 3T. But just importance of documentation. They're not alert oriented, probably distressed a little bit. But I put this just to make sure you're documenting well. So presented as a level 1 transfer at the outside hospital, bilateral rib fracture, right pneumo, had a chest tube placed on the right scapular fracture, thoracic fracture, bunch of facial fractures. And at the outside hospital was intubated, sedated, ended up getting a unit of whole blood and started on levo when they were transferred because they were getting hypotensive and there was no clear source of bleeding. So I think they went ahead and started levo for concerns of maybe neurogenic shock or something. En route, I think they were flown. The patient became hypotensive with systolics hovering around the 100. So I think they went up on the levo a little bit. And initially, when the patient was transferred over to us, everything was intact. Again, intubated, just multiple facial lacerations, right chest tube, laceration to the right knee. And this patient had a high shock index for us. I've talked about this a couple times, but the heart rate was greater than the systolic blood pressure, and so it was greater than 1. So if you've ever been to UAB, we're really quick to pull the trigger on giving blood. And so we started giving blood. We started giving blood, and the next thing, because I'm leading this, the patient is intubated, and all of a sudden his oxygen stats start dropping. So he's intubated and 100% FiO2, and I watch him go from 95 to 90 to 88, and I'm like, what is happening? So I start troubleshooting this. Anyone know the dopes mnemonic for post-intubation hypoxia? But essentially you walk through this dopes. D would be displacement of endotracheal tube. O is obstruction of the ET tube. P is the patient. Do they have a pneumothorax, PE, pulmonary edema, collapse, bronchospasm? E would be your equipment, and S would be the stacked breaths. This was from, I want to say like Life in the Fast Lane or something, but your very, very first step, if someone becomes hypoxic while intubated, is you're going to disconnect them from the ventilator and you're going to manually bag them on 100% FiO2. Your second is going to be MASH. It's going to be you're looking at movement of the chest during ventilation. So is their chest moving? Or do they, this next part was like arterial saturation. You aren't going to be able to send off an ABG. Is their skin, do they look pale? Are their lips blue? Can you tell if they're like having any oxygenation issue? And their hemodynamic stability. If the patient is difficult to bag, then you need to see if the patient lies with the endotracheal tube or with the patient. If there's little chest movement, there's probably a patient problem, but there could also be an ET tube problem. So this is where end tidal comes into play. So if your end tidal's low and it's or non-existent, it's probably not in the right place. But if you're having end tidal, then maybe this is the patient. Want to make sure to suction the ET tube well. I was looking up videos where they take a bougie also and they like try to clear any clearance or they suction out. You're doing whatever you can to get some movement of air and CO2. Then finally, you want to visualize the placement of the ET tube. I think it's not excusable if you're having problems, just take the video scope and look. It's not, very quick. It used to be more difficult with the direct, but just look. If there's reasonable chest movement in the patient, then it's probably a pneumothorax, lung collapse, pulmonary edema, bronchospasm, or PE. So listen to the lungs, look at the vital signs, make sure you're evaluating for tension pneumothorax. If the bag is easy to compress, but there's no chest movement, you need to look for dislodgement of the ET tube, which makes sense. Chest isn't rising, it's not in the right place. Or that there's a circuit problem somewhere. Is there a hole in the tube? Is the bag even connected type thing? All right, so this is where we get to a problem back to our patient. So they came over initially fine, and I'm watching their oxygen stats drop. We started giving them blood because their shock index was high. Fast exam was normal. Again, I'm looking through all the CT scans done at the outside hospital. I don't see anywhere this guy could be bleeding from. but his oxygen levels start dropping. So what I did is I immediately looked at the respiratory. We took him off the ventilator. We started bagging him. Doesn't really do much. And so the next thing is I'm asking them to look in the mouth, make sure he's not biting down, because at some point he was intubated, maybe with rock. So he might have been just paralyzed and he might be under sedated, biting down on the tube itself, causing a restriction. He wasn't biting down on it. He had a chest tube on the right. And so I needed to make sure that chest tube was okay. So I had someone actually go in and put their finger in the chest just to make sure it's in the right place and that that area was decompressed. He keeps dropping, and sooner or later he loses a pulse. So we had to decompress the other side as well, looking for a pneumothorax on the left. The other thing is that he had a lot of secretions in his mouth. And so we were trying to suction, and it wouldn't work. And so I almost called for a bronch to where we can get into the lungs and kind of suction out as much as we could. But in the trauma bay, there's a bunch of other things going on. Ultimately, he ended up losing a pulse. I think he got hypoxic and he lost a pulse. And so we did the whole trauma thing where we opened up his lungs on both sides, and there was really no source of bleeding. There was a report that his heart might have had fluid around it, so like a cardiac tamponade. His heart did not have fluid around it. There was no injury in the chest, no bleeding. His lungs looked okay. And so he was whisked up to the OR. Again, by this time, he had received about 6 liters of fluid or of blood for us. Okay. So in the OR, he received 5 more units. So he's gotten a bunch of blood. Again, I looked through the scans. There was no source of bleeding. There was no bleeding when we opened up his chest. He's gotten a lot of blood. He was taken to the OR. I had no clue why this happened. Was it neurogenic shock? Was there a spinal cord injury we missed or what? In the OR, he continued to have a problem with oxygenation. And so they actually did a bronch in the OR, and he had some bleeding in the lungs itself or some fluid in the lungs that were pink tinged. Again, they opened him up. There was nothing there at that time. They ended up calling ECMO. And because his oxygen levels had been low, they ended up calling it. So I've racked my head back and forth for years on what happened to this patient. And part of me wonders if there was some problem with oxygenation, but the fact that we gave him so much blood, we gave him so much volume that he wasn't losing if we overloaded his system. And so you can have acute lung injuries secondary to transfusions. You can have transfusions-related acute lung injury, which is your trolley, or you could have your TAGO, transfusion-associated circulatory overload. I think we might have put him in a TACO. So we overloaded his system, and all that fluid backed up into his lungs to where there's a bunch of fluid. So for the people given blood, I thought this was a good case just to show that, you know, if there's no clear source of bleeding and you give a lot of fluids, there is a poor outcome that can happen if you're giving a whole lot of blood. I don't foresee this happening, but I think it's something to keep in your mind. Big learning point from this case too is that if you've intubated someone, you're in transport and they're becoming hypoxic despite being on 100% O2 and you're bagging and everything, how to troubleshoot it. Remember your dope's mnemonic. I might have a stroke, and go through that. Any questions? That was a fun case. Well, not fun, but you get it. All right. This patient was like a 40, 50-year-old with hypertension, hyperlipidemia, pre-diabetes, so has risk factors, presented in the emergency department for chest pain and tightness, sent by urgent care, had an abnormal EKG and elevated troponin, so they sent him in. Chest pain had been going on for about a week and might be worse when she moves, but she really wasn't able to tell me what was going on. No runny nose, cough, fevers, chills, things like that. Whenever someone comes to the emergency department, I tell this to new learners and med students, and they're complaining of chest pain, there's about 7 life threats that I need to consider each and every time they come in. And part of when I'm asking them questions is I'm moving things up and down this list of whether or not I think it's likely. Sure, chest pain could be GERD, it could be like rib fractures, it could be other things, but that's what I'll decide on at the end of my complete workup for chest pain. So the 7 things would be acute coronary syndrome, heart attack, aortic dissection, cardiac tamponade, esophageal rupture. So this would be like a alcoholic with varices or cirrhotic with varices, right? And they've been coughing, they're spewing up a lot of blood. They'll have some chest pain with this. pulmonary embolism, pneumonia can cause this, or pneumothorax. And I think pneumothorax, either tall, skinny young person or someone that was just in an accident. So this was my MDM. I presented to the emergency department with chest tightness, of course, concern for heart attack, will obtain EKG troponin. Chest x-ray 1 will look for pneumonia, we'll look for pneumothorax, we'll look for the widened mediastinum in the middle to see if aortic dissection's a possibility, although I have a low suspicion for aortic dissection. We'll send off COVID, flu, RSV, and again, could be GERD, but we're going to wait until everything else is done to determine. Do y'all see what I'm missing on here? Out of the 7 life threats? Pulmonary embolism. Yeah, I know. I go back. Pulmonary embolism. I'm missing pulmonary embolism here. So the initial troponin that we got on this patient was 87, and the troponin was downtrending, so it was going down. So I didn't think it was necessarily a heart attack, but it was definitely something was stressing out the heart. And due to her age and risk factors, we were going to admit her to the hospital. This is her EKG. Looks pretty normal. Sinus rhythm. Only thing is that it's right axis deviation, but nothing crazy. Yeah, maybe a little bit. Probably because I loaded her or something. I don't know. Oh no, this is first. It's a first degree heart block. Yeah, it's a first degree heart block. But I mentioned heart score here. So chest pain is one of, like, I think, second most common complaint in the emergency department. So if we admitted everyone that came in with chest pain, it'd be an absolute disaster. So we kind of use the heart score. And as you can see, 1, does this sound like it could be a heart attack? Do they have sudden onset chest pain, diaphoresis? Were they nauseous, vomiting, pain going down the left shoulder, things like that? So if I'm highly suspicious, they get a 2. If I'm not, it's a 0. On their EKG, do they have a new left bundle branch block? Is there nonspecific repolarization, or do they have significant ST deviations? That would be my highly suspicious, moderately suspicious, or if it's normal, 0. Age plays a risk factor, so if they're greater than 65, they get a 2, less than 45, 1. And then their risk factors itself, which would be like hypertension, hyperlipidemia, diabetes, prior heart attack, that would make your risk factors higher one way or the other. And then your troponin. So is it normal, 1 to 3 times normal limit, or 3 times normal limit? So this patient, if I remember correctly, had a heart score of 6. 1, their troponin was really elevated. They had all the risk factors, age, and then I think I said moderately suspicious or something like that. So they had the 5 or 6. So they needed admission to the hospital. And so we admitted them. On physical exam, everything was pretty normal for her. Lungs sounded fine. Her chest wasn't tender. Vitals were okay. Her heart rate was 91, wasn't very high. She's satting 95% on room air. And so I mentioned PE. You can perk someone out, which is one of the tools we use to evaluate, do we need to work this patient up for PE? And these would be the things that you would need to qualify. They can't have a single thing on this list. Age greater than 50, yes, no. Heart rate 100, yes, no. Room air less than 95, yes, no. Unilateral leg swelling, hemoptysis, recent surgery travel, history of PE or DVT, hormone use. This patient had no for all of these except for 1. The age, she was greater than 50. So I can't perk her out, so she would fall under Wells for me. Wells would be like a low to moderate risk score for her. Where did I put it? I must have put both of them. Yeah. Wells would have been like a low to moderate risk for her just because of age, and so I would have sent off a D-dimer. The problem is I didn't send off a D-dimer. I finished out my shift after I had admitted her, and I'm upstairs signing the note, and I go back to look through all the labs to make sure I didn't miss anything, and I see there's a D-dimer, which was a good thing they ordered it. And I find out that the urgent care actually ordered the D-dimer. D-dimer was elevated to 873. That's high. I think normal is like 250. You can do age adjusted for people that are older because it's naturally going to be higher. And I even tried that. And even then it was still elevated. So I'm signing my note. And I say, well, signing my note, I noticed that the D-dimer is elevated. And I notified the admitting team. I was like, hey, she probably needs a CT scan. I really don't think it's PE because, 1, she's not tachycardic. She has no oxygen requirement. And they were like, yeah, that's weird, but yeah, we'll get the CT scan. Lo and behold, we get a CT scan, and this lady had a pretty significant pulmonary embolism. If you can see on the, I guess your left side, right side, there's this dark area where it's bright. So that would be her PE in her lungs. So she had a PE. She ended up getting consulted by cardiology, and they saw her, placed her on blood thinner, Lovenox shots, and she was shortly after discharged, but she's on Lovenox for a while. So my summary for this case is keep your differential broad and keep these 7 things in your mind at all times and always work through these 7. Because I got lucky there. But it's a team sport, so that's a good part. All right, last case. This was a cool one. This patient came in cardiac arrest, had a history of cardiac arrest in the past, and had like prolonged QT torsades arrest, and they think it was from some of the medications that she had been on. She had heart failure, coronary artery disease, and she had a history of PE, so she had all the things, honestly, and came in cardiac arrest. The report from you guys was that she was experiencing chest pain and then collapsed on the ground. I think she was doing something. It was around the holidays. Upon their arrival, the patient was found pulseless. Chest compressions were begun immediately. When EMS got there, they gave her 2 doses of epi, 2 doses of amiodarone. They initially shocked her, defibrillated her at 300 joules for a suspected VFib on the monitor. Patient was intubated in the field, right IO was placed. Okay, so they come into us, and I believe was still in arrest. Lucas device was going. We ended up doing a pulse check, and then shortly after, she had an organized rhythm and a pulse, so great job. IV access was poor, so we ended up doing a central line, arterial line, so we had access at this point in time. And patient was intubated, stable. We were given fluids. We got an EKG, and the EKG was concerning for right bundle branch block. Patient had a history of pulmonary embolism, so it's like pulmonary embolism can cause a right bundle, all kinds of EKG findings. She arrested, maybe hadn't been taking medications, we're not sure. So we're like, we need to get her to the CT scanner. But the differential for this arrest was very broad. Remember, she had a history of heart attack, PE. She had an arrest prior for prolonged QT, torsades. So we're keeping this pretty broad. The CT scan of her chest was normal, so it wasn't a PE. But she keeps coming back. On her way back, I keep getting called from staff that she keeps having runs of VTAC, and they're in bigeminy, so she'd have a normal beat, then a VTAC, beat, normal beat, VTAC. We ended up giving her 2 boluses of lidocaine. So if you remember, EMS gave her amiodarone, and then we gave her lidocaine and started her on a lidocaine drip. We held fentanyl. Does anyone know why we held fentanyl? Maybe. Fentanyl can also cause prolonged QT. And so because she had arrested on that, we were trying to avoid anything we can for the prolonged QT. We're also thinking possibly ECMO. These are some common medications that prolong QT. And so we were trying to avoid a lot of these. Again, fentanyl is one. If you look down towards the middle on the right, you see another medication that was given to her. Yeah, there's no way y'all would know that. There's no way anyone would know that. Again, at this point in the patient's care, we are trying to think of everything possible and just trying to optimize. But yeah, amiodarone can. So that's why we did lidocaine. I promise you, if we did not have a history of that, we would have used amiodarone. Big ones, QT prolonging, would be your Zofran and any nausea medications, which stinks because a lot of times these patients are nauseous. All right, so we obtained the EKG. I think we've already went through that. They're having continuous runs of VTAC on the monitor, started them on lidocaine, fentanyl paused. So this is that bigeminy that I'm talking about. So they'll have a normal beat and then a wide beat. So they're having bigeminal runs of VTAC. So this is kind of the same EKG, it's just looking more gross. We ended up admitting her to the hospital because like, of course, this is bad. One, you just arrested. And then I looked up her case through the hospital. She kept having runs of VTAC like this, right? So normal beat, normal beat, normal beat, VTAC. This isn't irregular to make me think torsades. This is runs of VTAC here. And so she was ultimately ended up having like sustained runs of VTAC. And so they ended up putting a pacemaker defibrillator, putting her on medications, and she got out of the hospital pretty quick. But this would be like y'all's protocols for stable wide complex QRS. So again, your amiodarone, your lidocaine. Amiodarone is what I would reach for first every time, unless I knew they had evidence of prolonged QT torsades in the past. I wanted to talk about this too. This is interesting. I'm hoping we can maybe do this live later when we're here. But when you put the pads on, typically you're putting them on, let's see, on the front, on the interior portions, right? There's been data that came out that said actually your vector change. So if you're putting it on the back and the front, or if you're doing dual sequential, is superior to just the typical what we do. The problem is for us is when we're in the field, someone's arresting, we're putting them on a Lucas, we're getting IV access. So it's hard to reach for that back pad or putting it on the front. You really have to have a high suspicion and you have to put it there first. If you've seen people come in and they're arresting and there's a report that they're in VTAC, VFib arrest, a lot of times what I'll do is I'll tell my staff while we're getting them over, we need to transition and put pads on the back. So again, typically you're on the front of the chest right there, but if you can put it on the front and back, this is going to be better for the patient, or if you can have both on each side and do two at once. This study was looking at survival was the main one, and the survival was greater in the patients that had a vector change or dual sequential defibrillation compared to the standard treatment. They actually had, I think, greater neurological outcomes with the dual sequential overall when compared to the typical one. So again, the Lucas device is going to be the limiting factor here. So if possible, throw one on the back and the front. But again, this is if you have a high suspicion of a VFib arrest. Cool. I'm done. That wasn't bad. I almost took up a full hour, right? 50 minutes. That ain't bad. Hit me, chat. Hit me, chat.
Thank you, Dr. Kirby. Dr. Ferguson wanted me to remind everybody that the state is okay with using spinal motion restriction for blunt trauma with obvious paralysis.
Yes. Yeah.
So I think we all got that, but just to make sure you all understand. Great cases. Thank you, Dr. Kirby. Does anybody in the room have any questions for Dr. Kirby?
I'll ask the question to somebody. The state is okay with vector changes as long as you can.
I don't know of anything in the protocols or EMS rules that says you can't do it. Okay.
If the outcome is good, you're not going to.
I don't even know if it's in there, to be honest. Is it in there?
It's not. It's not. It's not currently mentioned. I will also mention that the data is mixed on dual sequence defibrillation. There's also studies that show for outcomes. A lot of people speculate that that's because of operational changes on the scene. I would hypothesize that most of the time when vector changes work, it's because the pads were placed in such a way that the current was going through the subcutaneous tissue and not through the heart in the first place.
Like a bigger patient.
Well, no, because the pads are both being put on the anterior of the patient. One pad should be put lateral on the patient.
Yeah, that's fair.
And I've just seen that quite a bit. So I have no data to support that. I just think that that's probably a problem.
Yeah. I also, like, I know the most important things in cardiac arrest are going to be chest compressions, timely epi, timely shock, right? Just do those things well and everything else will fall into place. Mm-hmm.
Trying to get the most amount of energy into the heart. So why would we ever start on the lower end of, like with the monitor, we charge the 120, then we go to 150, or depending on your monitor.
It's a great question.
Never just start at the highest energy level.
Well,
it's a great
your first statement is not agreed upon. You're not trying to get the highest amount of energy into the heart. You're trying to get the least amount of energy that successfully converts the rhythm. Every time you shock somebody, you damage their heart.
Yeah, and there's an idea of like compounding levels. So if you shock them at 120 and then you shock them at 220, you should have just went to 200, like, so it's hard to, does that make sense?
Yeah, so for those of you online, it was just looked up in the protocol, and the Alabama protocol does provide for dual sequential and vector change for persistent VFib.
Dr. Sullivan, what do you start at if you're like defibrillating someone? That's a very fair answer. I usually just light them up. So, yeah.
Lack of pulse is going to come back with
Well, that's my, yeah. Berg is turning over right now.
Yeah, Dr. Ferguson texted me, just mentioned that, when we talk about things like dual sequential and vector change, that's really for when you're doing everything else perfect. Those are the things that you worry about.
Yeah. Thank you. Yes.
All right, everybody. Thanks, everybody, for being here. Just a reminder, we've got Dr. Sullivan coming up after the break. Everybody, welcome back. We're going to get started back with Dr. Sullivan's going to be talking to us about some pediatric critical care.
Thank you, Uncle Wes. This will be not the best pediatrics talk you've ever heard, but hopefully not the worst. Yeah, probably the worst one this week for sure. There are some good pictures in it, at least, of what all I did this weekend, which is just run amok in Mississippi, which is good. My wife is on a trip with her mom, and so I've been like being a single dad and run around taking cool pictures and run around the woods with my kids. So there's at least some like cool pictures and stuff. So one of my good friends I worked up in DC before I went back to medical school. He was over in Spain and bought this knife from this steel maker in Toledo that has been making steel and blades since like, I think they go back to like 3 BC or something like that. It's all been made in the same location. So this steel has been a part of like all kinds of history and all that, and now it's stuck in a pine tree in Mississippi somewhere. So hung out with my dog, my doofus golden retriever. He's also very handsome, but he does not have any gyri in his brain, so he doesn't do much other than eat and play. But anyway, some good stuff, at least some high notes for the talk, other than pediatric stuff, which I will try to communicate as best I can. But what we'll talk about is, I think, some higher yield topics. There's no way to cover all of pediatrics in a lecture unless you all wanted to sit here for the rest of the day, which I know you don't. So we'll talk about some of the more common kind of critical presentations of kids, particularly like airway, particular pathologies like status epilepticus, trauma, head trauma, things like that. The stuff that you're going to see when the kid is sick. The reason this is important, about 25% of ED visits are pediatrics. So particularly if you're working in the community in an ER, like, you're going to see pediatrics. Pediatrics is very complex. There are entire specialties dedicated to pediatrics where doctors do not see a single adult patient for the rest of their careers because it's different. Pediatrics is not just a small adult. Everything is unique. Medicines are specific. Physiology is different. They compensate differently. Everything is different. But according to the American Academy of Pediatrics, it's going to be 6 to 10% of your calls. So this is something that none of us can get away from. So it is our responsibility to be proficient in taking care of kids. So we'll talk through like 5 or 6 different critical care scenarios, all to do with trauma, status asthmaticus, respiratory failure, shock, things of that nature. There's going to be a little bit of doctor stuff in here, like there's going to be antibiotics and things like that. This is kind of a dual purpose lecture that can go all the way from the top to the bottom as far as your training levels go. So we will hit it all and hopefully take some high yield topics away. We always have to say these weird things about financial disclosures, like I'm a UAB fellow, so I have none of those, but I've got these two. If any of you, which I'm sure you do, have daughters, you know that I need financial disclosures and I need y'all to come up with something. I will take anything that I can get. And then I've got this guy on the right who we funded several orthopedic surgeons' vacations to various places, I'm sure already, and he's not before. And I screwed around and did this, so now there's going to be a third one. So obviously I haven't learned my lesson. So remember, financial disclosures, I'm open. So to jump right into it, anytime you see a picture, I guess there will be a little bit of a transition point. We'll take a breather and I'll talk about whatever's on the screen and then we'll switch into the next subject. But I found this, I guess, about a year ago when I was going through this lecture for residents. I think we can all safely say that when you're dealing with a different patient population, particularly kids, everything feels more valuable, right? Like it feels higher stakes. It feels like this is more important. It just is what it is. It's because maybe kids are more important. Maybe it's because they have more potential, more life ahead of them. And you're going to feel that pressure when you take care of kids. So I think, and I say this pretty much every lecture that I give on any particular subject, I think that the stress of what you guys have to do in the field is to such a level that you need to cognitively offload as much as you can. So I personally, in the emergency department, particularly when taking care of sick kids, I like for the least amount of outcome of this patient, the least amount of things that happen depend on my cognitive thinking. I want my brain to work on the most critical aspects of this case, and I want the small stuff to be taken care of by some algorithms or by some resources or tools that I can use to help take care of the patient. I want as little of the calculations and medications, as little of my, full-fledged assessments to be something that I have to think about every step of the process. I want my brain to work on big picture and then critical procedures, things that I have to do, and I want it regimented as much as I can. Cognitive offload is the word I'm going at here. So, pediatric assessment tool. We met some guys up from New York State at a conference a couple of weeks ago, and I actually brought this up in conversation to one of them. I think this is a pretty good tool here. It's like ABC, just like it would be for trauma, but it's a general assessment of a pediatric patient. So it starts with airway and appearance. So do they look normal or not? Is the patient crying? Is the patient able to talk? Is the patient having normal responses? Is he looking at you? Is he looking at his parents? Is he doing all these things? Or is he not really registering all these things? Is he floppy? Is he weak looking? Does he not hold his head up? All of these things can cue you in that maybe this kid is sicker than they might appear, because kids don't look that sick until they are very sick. So there's some little physical exam cues that you can pick up on that might help you kind of parse that out a little earlier. So basically the appearance is reflecting kind of their neurostatus, right? And their overall perfusion, and kind of how their body is working and what you may not be seeing that's so obvious. Next, we kind of go to their breathing, their work of breathing. So work of breathing is kind of judged by just their visible effort, right? So retractions, nasal flaring, head bobbing, tripoding, audible abnormal breath sounds like stridor or wheezing, things of that nature. And then we go to the circulation. So we look at their skin. Does their skin look normal? Is it warm or is it cool? Are they mottled? Are they gray looking? Are they blue? Are there signs of bleeding? Are there all those things? So kind of taking that approach can kind of get you a general sense of what's going on, even if you have no information going into this call with a sick kid. So like I said, ABCs, I like to keep things simple. So on the left was this weekend. Didn't have anybody to babysit yesterday morning, so I couldn't go hunt by myself. So I just took the whole hunting crew with me, dog and kids included, and that's probably one of my favorite trail camera pictures that's come across my phone lately. And then on the right, my son kind of hopped over in that bush right there while I wasn't looking, and hid out and told me that he was hunting me, and he'd have probably got me. Anyway, that's like a little pine stand on the back of our property that brings me a lot of joy. So to jump into the airway, big deal here. Pediatric airways are tough. Pediatric airways are scary, and they are high stakes. And why is it important? So airway issues, hypoxia is the leading cause of pediatric arrest out there. So that is by far and away the reason that kids get into trouble is because of their airway. It also matters because their anatomy is rough. They have shorter tracheas, they have floppier epiglottis, they have higher oxygen demand, and when they fall off a cliff, they fall off very hard. So pediatric airways are much more difficult to deal with and much more critical. So from the anatomy standpoint, they have more narrow airways. They have a larger tongue that you have to navigate. They have a floppy epiglottis. So all of this kind of decreases your view and makes it harder to pass a tube. So how do we look at these kids? So if we're thinking about that assessment triangle, and we're thinking about our ABCs, like how do they look? Is the kid sitting up and tripoding? Is the kid drooling? Is the kid making noise every time he breathes, even at rest? Are there wheezes throughout his lung fields? Is this newly diagnosed asthma? And so on and so forth. And from a breathing standpoint, like how is he working? How is he doing? From a circulation standpoint, does the patient have good distal pulses? Does he appear perfused? So we take that approach into every situation, including airway, right? So as far as like getting yourself set up for success from this standpoint, if we're assessing a patient's airway, you want to get them in good position, right? So if the kid's in any kind of respiratory distress or anything of that nature, you want to get them into a good position, and we'll talk about that here shortly. So if we're making the decision, so we'll take all this in the context of going ahead and we're going to make a decision to intervene on this patient, right? So when we talk about the airway portion or the pediatric airway, let's take this from a context of like we're doing something about this, right? So we'll take that frame of mind into the rest of these slides. So from a pre-oxygenation standpoint, so this is going to be, in my opinion, one of the single most important things that you can do to set yourself up for success before attempting anything. And sometimes just adequate pre-oxygenation may actually fix your problem in the field and give you enough time to get to where there's more definitive intervention. So if you're using a face mask, using one that's tight fitting, using 100% FiO2, upwards of 3 minutes if you're going to make an intervention when possible. A lot of times the kids don't like to wear a mask, right? So getting the mask as close to their face as you can, holding it close to the face or just off the face or having a parent hold it will sometimes kind of increase your success with getting it close to them. Utilizing sedation if you need to. That can also kind of facilitate better pre-oxygenation and pulling a patient out of hypoxia and therefore pulling them a bit out of distress. We like to keep that kind of towards the end of our interventions, but always have that kind of in the back of your mind. So the physiologic goal here is to kind of replace the nitrogen in the lungs and bring up obviously their oxygenation status to hopefully improve their perfusion and their mental status. So all of this from a pre-oxygenation standpoint is applicable to our adult patients too, right? There's a lot of words on the screen, but basically pre-oxygenation should be something that's in all of your toolboxes. And anytime you're dealing with any kind of airway issue where you may or may not be dealing with hypoxia, pre-oxygenation should be your first step in all of these situations. You shouldn't be taking an airway without adequate pre-oxygenation. It doesn't hurt, and it almost absolutely helps. The data doesn't quite show that, but it shows, at least in adults, that it probably shows a lot of improvement for these patients. So pediatrics are all the same. You want a happy kid with a nasal cannula or a non-rebreather or whatever you can get on them, just like our adult populations. So anatomy, back to that. This is your biggest enemy when it comes to pediatrics. They're anatomically smaller, they're more vulnerable, meaning even minimal edema can cause major airway obstruction and significantly worsen your view. Congenital airway anomalies. A lot of the kids that are really sick were really sick at baseline. A lot of them have chronic conditions like Down syndrome or Pierre Robin or things like that, de Jour's, a lot of things that can already cause abnormalities in their upper respiratory anatomy. That's further complicated by the small size and whatever pathology is going on with them. So being aware of kind of what already is there and then their congenital abnormalities that they may have underlying going into it is particularly important. So infants, they also have a larger occiput, so kind of the back of their head there. A lot of times you'll you'll require like a shoulder roll, which we'll show here, to kind of pop that patient up and get them into appropriate position. So if you're planning on taking an airway, right? So one of the best things you can do is kind of stop and step back and take your own pulse, right? Particularly with kids. The way that I like to go about kids is doing everything to the max, right? So a lot of times we have video scopes and things like that that kind of alleviate and can kind of help us get away with things that we wouldn't normally get away with if we were doing like a direct intubation. And I'm certainly guilty of that. I've intubated a ton of adults in poor positions and things like that, and you get away with it because you have the camera. With kids, I would say, again, with the emphasis on like things feel a little more high stakes and a little more important, I want to emphasize like setting yourself up for success and taking every step that you feel like you should take to the max to set yourself up for success here. So for these patients, like if you're going to intervene on an adult, like you might put a shoulder roll under, you might do a little bit of repositioning or set them up in a sniffing position or whatever. But I would recommend with kids that you take every one of these steps and actually do them all. So like putting a shoulder roll under the patient, so propping up their chest to where you get everything in good alignment, getting a headrest up underneath them as well. So you bring, if you can kind of see this angle from their tragus here down to kind of their sternal notch, getting everything in a good anatomical plane, and then getting also kind of, you can see their face is lifted, the chin is up. So you're pulling as much of that anatomy away from the actual trachea that you possibly can. So I would recommend with these patients taking every step in the process and maximizing it as best you can. So what equipment are we using? Again, with the pediatrics, we're pre-oxygenating, and I would recommend utilizing every tool in your toolbox, right? So if you're going to intubate a kid, I would have an OPA or an MPA in if I could, if not both. I want as much of that anatomy pulled away. I want as much oxygen flowing as best it can to buy me more time, right? So the last pediatric intubation that I did was like a 30 set. The kid was born premature, was born at like 32 weeks. This was like 6 weeks later. He had been in ICU for probably 4 weeks, went home, got a pneumonia, was jacked up. And so this kid was like 5 pounds, right? Took me 5 attempts. It was tough. And the only reason that I was able to take that much time and spend like 12 minutes trying to get this airway and not have the kid code is because we were pre-oxygenating the crap out of him. We had a high flow nasal cannula on, so we're blowing oxygen down there constantly. Obviously, we're taking him off and bagging him in between and doing all the things we need to do from that standpoint. But even with all of the interventions, with everything that we had, I did not have a video scope for the most part of this. I had to DL it, and it was tough. And so I would recommend having all these things on hand and utilizing all your tools to prevent that, like a kid arresting on you, because that airway is going to be tough. So an OPA and an MPA. How do we measure an OPA? So measure from the center of the incisors to the angle of the mandible. And I have another schematic on that here shortly. And the MPA from the tragus to the from the tragus to the tip of the nose. We also pay some attention to the nostril diameter, but mostly it's about size, and you should find it. Endotracheal tubes. We have 2 different types of tubes that we use for kids. We have the cuffed and the uncuffed. Typically, I would prepare multiple sizes. I would take these rules here, like an uncuffed ET tube. The way we go for that is we take the patient's age, we add 4, and then divide that number by 4. And then a cuff tube, we do that with 3.5. So you come out, if you've got a newborn child, usually around 3 or 3.5. But let's say for this example, we've got a 6-year-old. So 6 plus 4 is 10 divided by 4. What is that? Roughly 3-ish. So that's still a small tube. But I would have multiple tubes at my disposal. I would have size up and size down and have everything there that I felt like I could need. because if you go in and try to make your intubation, agitate that big epiglottis and things like that and cause a bunch of edema, you want to have a smaller tube that you can try to pass on your second and third attempts. As far as the depth goes, if you're inserting an ET tube, usually it is the tube size times 3. Get that shorter tracheus. A lot of times you will be at risk of tube dislodgement, but if you stick to that size rule, you can typically find yourself in about appropriate position. So there's our tip to tragus there for NPA. And I'll go ahead and throw in a plug for one of these two things. So with any pediatric call or any pediatric patient that I take care of in the emergency department, 2 things that you want to have handy is a Broslo tape. And in my personal opinion, if you're going to be administering medications to kids, there's an app called PediStat that will take the kids. You can do it multiple ways. You can calculate weight-based dosing by age, so it will estimate an approximate or what should be roughly the patient's weight and get you exact dosages. Or if you know the patient's weight, you can put it in by kilograms or pounds, and it will pop you out the weight-based dosing. So for things like push dose pressors for kids, for fluid boluses, for seizure medications, for all of those things, I like to have, like I said, cognitive offload. So I like to have my resources available that basically tell me what to do. That way I don't have to think about it. So if you've got a toddler that's 10 kilograms, you pop your Broslo tape off, and instead of trying to make a calculation on what size tubes you need or what size this or that you need, you have it spelled out for you right there. So you take that little bit of thinking away from yourself. You eliminate some margin for error there. You make it much wider. Much more difficult for yourself to choose the wrong thing in this situation, which is easy to do with the stress. So drugs, again, PediStat, worth the money. I think it's like $5 a year on the App Store. So as you can see, and I'm not going to go into like all of these or try to teach you these dosages or have you remember it when you leave here. The point of this is that a lot of medications have weight-based dosing and a lot of them are very different. So like your atropine dose of 0.01 to 0.02 mg per kg, your ketamine 1 to 2, your Versed 0.1 to 0.4, propofol 0.5 to 1. So there's all these numbers, right? There's all these like 1s and 0.6s and 2s and all that. I would have this on hand. I would have something on hand to help you not have to do these things, remember these things, and calculate these things on your own. But those are our kind of common medications and their common dosages for intubation in children. Atropine is something I would have on hand for pretty much any pediatric intubation. If there's any concern whatsoever for shock of pretty much any sort, a lot of times I will administer atropine just preemptively, even if their vitals are somewhat normal. And push dose epi, I think is very useful, especially for your bigger kids. And I usually make a plug for that in pretty much everything. But as far as push dose epi goes, that's a 0.5 to 1 mic per kilogram IV push on those kids. So you've got to have a little bit more of a sensitive syringe from that standpoint to make smaller dosages. But I like to have those things handy. So confirmation, as with any airway, but particularly with kids, we want to make our confirmations, right? So confirming our depth. So our 3 times the tube size, making sure that we're in the right appropriate position. We're visualizing the tube passing through the cords. We're looking for chest rise. We're looking for mist on the ET tube. But most importantly, we're assessing for end-tidal CO2. That again can't be missed in today's age. End-tidal is pretty much uniformly available, at least in some form or fashion, but typically exhaled end-tidal CO2 is available to most places. So this is the gold standard now, and we got to have it to protect yourself and to protect patients. And then obviously once you're in the X-ray, or once you're in the ED, getting an X-ray to make sure everything's in appropriate position. Vent settings, this one's kind of complex. You could read through these. I'm not going to try to teach you vent settings for a pediatric patient because this could be an entire separate lecture in itself. These are all pretty age specific and size specific, and they kind of focus on avoiding volume trauma and barotrauma, while also ensuring adequate ventilation and oxygenation, obviously. So neonates and kind of premature babies, they usually take some pressure control ventilation. So usually these are very high respiratory rates, upwards of like 40 to 50, 30 to 40 for preemies and neonates. Lower peeps around 3 to 6. Short inspiratory times, you get it. It's pretty detailed. But if you want to grab a screenshot or grab a picture of that, that's a pretty good spot from EM Crit that gives you at least a general place to start with vent settings for kids. And I've often referred to this when intubating in the community. But don't forget, if you ever get into trouble, difficult airways, anything of that nature, can't get the tube, supraglottic airway devices, LMAs, IGLs can provide a quick fix for you and really bail you out of a sticky situation. So bottom line on these, I would always have these immediately available in any situation to do with a pediatric airway. And again, the Broslow tape will tell you which one to grab, depending on what device that your service employs. So these are my girls. That's my wife, Chrissy, on the left. And this is about a year ago, my daughter, Stella, but that's probably my favorite picture that I ever took of her out at our farm. So on to shock. So why does this matter? Shock is very time sensitive. We have all kinds of metrics. They fuss at us all the time in the hospital about getting fluids on board, getting lactates, getting antibiotics on board when a patient is recognized to be in any form of sepsis or be at risk of shock. So it's a time-sensitive emergency, and the earlier we intervene on it, the better patients do. This has been shown time and time again. So there's all kinds of types of shock, right? So there's hypovolemic shock, there's septic shock, distributive, hemorrhagic shock. There's all these things, right? But the most important part is that you're taking the clinical context of these patients and then recognizing the early signs of shock in kids, and intervening before you get into kind of the late stages. So importantly for shock in children, tachycardia is kind of your earliest sign and probably your most reliable one, because hypotension in children is kind of a late finding. If you've got a hypotensive kid, you're late to the game. And so you better be intervening before they get to that stage. As I said, they kind of compensate really well. And so they go until they can't anymore, and then they fall off the cliff really hard. So volume resuscitation, kind of our parameters for fluids that we give to kids. So in our neonates, it's usually like 10 cc's per kg boluses. Our pediatrics are somewhere between 20 and 30. I think that was taken directly from the site. So you can give upwards of like 40 to 60 cc's per kg inside the first hour if this kid is like a refractory shock to your initial boluses. But if you start getting up into the 40 to 60 per kg kind of area, you got to start thinking about vasopressors at that point. From a maintenance rate rule, if you're taking kids, like say you're transporting from one facility to another, we use a very similar rate as we do for adults. We use this 4-2-1 rule. So you're doing like 4 cc's per kg for the first 10, 2 for the next 10, and then 1 for every kg over 20. Our blood products, the way we give that is typically in infants, it's like a 15 to 20 cc's per kg bolus. Children, in kind of the 5-year-old range and up, once they start getting bigger, you start talking about like giving them a half unit to a full unit. And then your adolescence is where you can start transitioning into kind of the adult volume resuscitation and give them full units. As far as access goes, this is a place that maybe, in an ER or something like that, it's used to treating adults, can kind of get into trouble, right? Everybody wants the IV because it's more reliable. But the literature has shown that drilling these patients is helps result in better outcomes, right? So getting access early, even if it is an IO, is associated with better outcomes even in kids. So we drill, baby, drill them early. Don't mess around with trying to get IV access. If you can't get one in a critical situation where you're recognizing shock, drill the patients early. Go ahead and get that in and establish access because it can make a huge difference. Where do we do this? Proximal tibia is the most common site and probably the most accessible and easy one. And this is where I would always recommend that you start. Distal femur is also a location where you can go to with kids, usually just one finger up and one finger kind of medial. And the humeral head also in kids, this is a little bit easier of a target. When you get into adults, this may be there may be more tissue up here. But that's another viable option for you. We've got the pediatric pinks, so the real small needles for your neonates and your infants. The blue is what we use for kind of your average size child from about a year or so older. And then your adults are kind of for the obese children, adolescents, teenagers, things like that. The ones that are adult sized. But your pink and your blue are what you're going to be dealing with typically with kids. It's this little odd looking skeleton there, shows you kind of your classic locations for pediatric IOs. Some more pictures. Dog, tractor, the bro sesh in our family. More sepsis, or more shock, but pediatric sepsis. So this is going to be a common presentation of sick kids, the sepsis, whether that's a respiratory infection. You'll get some sick kids with just viral infection that meet all the sepsis criteria. But we'll talk more about like pneumonias, UTIs, pylos, meningitis, those type things. This is going to be, fairly heavy on antibiotics and things of that nature, but we'll kind of run through it. You'll find kids get septic from soft tissue infections like staph scalded skin syndrome, cellulitis, big abscess. But this is particularly important in kids who are immune suppressed. So say kids that have some type of underlying disease where they are immune deficient for whatever reason, whether they are like immune globulin deficient, they have cancer, they're on some kind of therapy that makes them more prone. This is something that you got to be kind of have your ears perked up about. Our sepsis pathway at the Children's Hospital, I think is very good. It's simple, like the things that I like. It's easy to follow, and it's easy to access. So this kind of just takes you through and shows you your quick assessment where you kind of determine that this patient likely is infected. If they have any form of shock, we're giving their 20 cc's per kg of LR or normal saline. You guys are typically not giving antibiotics out in the field, but inside the first like 20 to 30 minutes, we're giving upwards of 60 cc's per kg. If we're not getting a good clinical improvement, moving over into fluid refractory side on the left there, and considering our vasopressors. So antibiotic selection, not to hit it too hard, but basically you're going to see a lot of vancomycin and ceftriaxone. These are the two workhorses, just like we have vancomycin and Zosyn or vancomycin and cefepime for adults. Vancomycin is kind of your workhorse here. For intra-abdominal stuff, if you got a kid with like appendicitis that you're treating with antibiotics in anticipation of surgical intervention, that's going to be more of your Zosyn category. We do utilize cefepime in kids when you have like neutropenic fever. So those are your patients that, say if you're transporting the children's, a patient that has sepsis or whatever, that's actively undergoing chemotherapy or something like that. So they're immune suppressed. Those are the ones that we're reaching for, cefepime and or Zosyn. And then we've got some oxacillin and clindamycin for things like toxic shock syndrome or staph scalded skin syndrome. So just some names to be familiar with there. That's kind of a simple chart. We're seeing things for example, meningitis, your vancomycin ceftriaxone versus like neonatal infections. You might see some ampicillin, cefotaxime, acyclovir, and gentamicin. So a little bit of Taylor for the little bitty ones. As far as our vasopressors go, epinephrine is kind of the front line versus Levophed or norepinephrine for adults. Epinephrine is a lot of times our kind of first line vasopressor for kids. So you'll see it anywhere from 0.05 to 1 mic per kg per minute for these kids. As stated earlier, a microdose is somewhere between like 0.5 to 1 mic per kg. So these are smaller doses, particularly in smaller kids. Make it up in the same way, a 10 cc per syringe, push 1 cc of the normal saline out and withdraw 1 of your code dose epi into it. And then from there, if you have like a 3-way stopcock, you can move it into some more sensitive, like into like a 5 cc or a 3 cc syringe if you're dealing with a little bitty kid, but you want some epinephrine as a push dose to help you out. Our Levo for a drip is 0.05 to 1 mic per kg per minute as well. Phenylephrine, dobutamine, and dopamine. Dobutamine more so for the kids that say they have some type of congenital heart defect that gives them some form of heart failure and they need some inotropy. Dopamine is still used. Saw it some in the PICU, but not near as much as the others. So our big dogs, epi, norepi, phenylephrine, and dobutamine are the ones that you're going to see the most of. This is a lot of words, but these are really good algorithms for septic shock and taking care of kids. From y'all's standpoint, we're kind of skipping 2, 3, and 4 in the algorithm on the left once you recognize that this patient's likely in septic shock. But obtaining IV and IO access and administering fluid boluses if shock is present, and then vasoactive agents if you're in a prolonged transport and they're fluid refractory. But most of the time it's just gas or flying them there quickly. Some more pictures, more hunts. The trauma. So why does this matter? Trauma is the leading cause of death in kids, just as hypoxia is the leading cause of arrest. This is the leading cause of death in kids, particularly hemorrhagic shock and particularly reversible causes. So this is a major intervention point, as you guys know. And I know that out here at Springville, y'all are on the front end of pre-hospital whole blood. So this is the reason for that. So again, I would recommend the use of like a simple survey. So the ABCDEs, looking for things that you can intervene on, like a tension pneumothorax, or other things to identify, such as a tamponade or concern for intra-abdominal trauma. How we're going to manage this is direct pressure, tourniquets, trying to stop our bleeding, right? Giving crystalloid fluids is kind of where the literature still is as far as kids go. Not that blood is not better, because we know that it is. We just don't have quite the research yet to definitively state that. So the recommendations, I believe, in the protocols, unless I'm mistaken, is still fluid bolus initially. But we're headed rapidly towards whole blood, as is kind of pediatric emergency medicine. Believe their data is still also calling for the 1-to-1-to-1 ratio rather than the whole blood, but I think whole blood is where we're headed. If you have access to ultrasound in the pre-hospital setting, which is starting to become a thing, doing your FAST and eFAST to try to identify what your pathology is, whether that's a tension or intra-abdominal hemorrhage, and then obviously CT and X-ray in the emergency department, and transferring the patient to a trauma center if that is indicated. And just to reiterate, these kids compensate well, and they also compensate well in hemorrhagic shock. So a normal blood pressure in the setting of tachycardia or in the setting of the appropriate mechanism doesn't rule out early hemorrhagic shock in these kids. So the key here is to recognize and treat the shock early, right? So before they start to get hypotensive, because as stated, if you get a hypotensive child, you are behind the ball. So once they start to show signs of shock, you may have lost up to 25% of your blood volume. So like I said, this is tachycardia, delayed cap refill, and cool extremities before you lose that full-fledged blood pressure response. So initial steps, 20 cc's per kg bolus, normal saline or LR. LR is recommended from Children's of Alabama, typically through their sepsis stuff. LR is probably the better fluid bolus in this situation as well. So we give them that by the algorithm, give them 20 cc per kg. We look for improved perfusion and see if they're responding to this. If they're not and we have blood, this is where we like to give it. But getting some form of volume control in with these patients when there's signs of shock is where we want to go. So an estimated volume trigger, these are gross estimations of how much blood kids have to lose before they actually start to show signs of hemodynamic instability. So that's upwards of like 55 cc's per kg for a neonate, 50 per kg for like, say, a 25 kg infant. That's a lot of blood, given their blood volume. Upwards of 45 for the 25 to 50 kg child, and then greater than that, usually about 40 cc's per kg before they start falling off. So a lot of blood volume has to be lost before these kids really start showing a bunch of external signs. So the official recommendations. So this is straight from the kind of pediatric trauma. A fluid bolus of 20 cc's kg of warm normal saline or lactated ringers given rapidly. It says over 10 to 15 minutes, but as kind of a bolus. I think you can and probably should start with PRBCs or whole blood if that's what you have. If the patient is presenting to you with mechanism of traumatic injury, obvious traumatic injuries, and then shock physiology. The PIM world seems to be moving to whole blood products because it contains all of your products inside of one unit of fluid rather than in its components. So we're moving that direction, but not quite there. But I think it's obvious that this is the way, and that kids do better with this. TXA, again, it's a weight-based dosing, but it can be used safely in children. There's still studies that are ongoing, but there's evidence of improved survivability, particularly when given in trauma. Some more change. A little girl is 2. She wanted to climb up the ladder stand, so I watched her close. Unfortunately, we didn't need a trauma alert for her, but she was a little too brave and maybe a little too big for her britches. Anyway, head trauma. Traumatic brain injury, another big cause of morbidity and mortality in children. So our goals of management is preventing secondary brain injury. So what that means is like maintaining their cerebral perfusion, and really identifying what may be going on and getting them to appropriate care. Down on the bottom, you can see like up top or top left, there is an epidural hematoma. You can kind of see more of a cone-shaped hemorrhage that's causing a lot of mass effect. The second image, you see more of a crescent-shaped subdural hematoma. The star of death on the third one, you can kind of see it looks a little bit like a starfish in the center of the brain for subarachnoid hemorrhage. And then you've got a little bit of subdural and interventric on the image on the right. So 5 parameters that we have to really address and get after when treating a pediatric patient with a severe head injury. So hypotension, so maintaining a good normal systolic blood pressure and euvolemia, maintaining their oxygen status and making sure that our sats are appropriate and as high as they can be, to make sure that we get good oxygen supply to injured tissues. Addressing hypothermia, so making sure these patients do not become hypothermic, keeping them squared away from that standpoint, just as we do in adult trauma. Hypoglycemia, the DEFG and our ABCs, don't ever forget the glucose, and then intracranial pressures. So we're elevating the head of the bed to 30 degrees. We're taking off our C-collar if we can, or if it's indicated. And that's happening typically in the ED. In y'all's case, if there's a severe head trauma concern for C-spine injury, leave the collar on by all means. But treating pain and anxiety, treating seizures, and normocapnia. In the ER, this is a place where hyperosmolar therapy might come into play. So you might be giving mannitol, most commonly giving normal saline to patients to reduce brain edema. And then in the ER, we kind of use our PCARN and Nexus rules on whether or not we should pursue advanced imaging for patients with mechanisms of significant head injury. We use those. They're great, but you got to trust your gut on these patients. So when do we need to escalate and consider like trauma center transfer? This is when a patient has a poor GCS status, they have focal neurological deficits, or they have a pupillary abnormality. Whether or not there's concern for a depressed skull fracture, or if there is an open one, worsening mental status, and then obviously our CT findings in the ED. So this is bleed, midline shift, herniation. All of those things are neurosurgical emergencies. And particularly if there's evidence of like non-accidental trauma, this might be a reason to take them to a pediatric hospital or something where there's a little bit more resources. Sometimes you can't really pick that up from the scene, but there's been several times where I've been at kind of some satellite hospitals and picked up on that and had to come up with reasons to transfer the kid down to Children's to get a little bit more checkout rather than alerting them that you were suspicious of that. So that's something to be on the lookout for in pediatric trauma if you're picking up from the house and the story doesn't quite fit. So keep your suspicions up for that. So this is our farmhouse. Pretty cold this weekend, so I had the gas heater on the right going and a good fire in the fireplace. It's pretty awesome. If any of you duck hunt, you'll know that hooded merganser is like the pinnacle of duck trophies. No, not at all. Considering none of y'all reacted to the merganser comment, I guess none of y'all really, yeah. Merganser is not a prized possession, but he got shot anyway. The one with the white. This one here. Oh no. And this is Jeff right here, the deer. So he's got two big long pikes. Yeah, he obviously does not have a whole lot of sense. So anyway, his name is Jeff. Yeah, that's Jeff. All right, so status. We'll run through this because we're kind of running towards the end of our time. So status epilepticus, so prolonged seizures greater than 5 minutes. So once you get over that 5-minute mark, that's when we start to intervene. That's why parents with kids with epilepsy have a diastat pen, because that's when you really start to kind of cook brain, right? So time is brain with these as well. 10 to 20% of pediatric seizures do present a status, so this is not an uncommon finding. Assessment, making sure that we don't need to take an airway, that the patient does not have any vital sign abnormalities. Make sure that this is a usual seizure type, that the patient has a history of such, whether this is focal or whether this is generalized. Making sure our glucose is normal and our electrolytes are normal, and looking for external signs of trauma, other reasons for a seizure, or looking for infectious type symptoms or stories. If this could be like meningitis or something along those lines, would be something you want to be aware of and communicate quickly. So our management typically has been benzodiazepines, so lorazepam 0.1 mg per kg, or midazolam 0.2 mg per kg. You can give those IV or IM. Our second line agents of Keppra, like 40 mg per kg, or phosphine 20 mg per kg. Typically, that's more of an ED management deal. And then phenobarb is still one of our priorities for neonates. In refractory cases, we consider intubating these patients and start them on propofol or Versed drips or things like that to help control the seizures, while also maintaining a good airway from that standpoint. So we have to consider our fever seizures, so our typical kind of things that are benign that we see in kids, traumatic, metabolic, or bad infections like bad sepsis, bad meningitis, or something along those lines. Don't be afraid to give benzos early and don't underdose them. We'd rather have the patient stop and you intervene on their hemodynamics or support them from a respiratory standpoint rather than have them seize for a prolonged period of time. It's a good algorithm. We won't go through. So for us, for a status, status epilepticus workup. Blood glucose, if indicated, we consider anticonvulsant levels. This is patient not taking their medications or things like that. So we get our full panel of labs. We check for infectious process. We do CT heads if we're concerned or this is a new seizure. Tox studies and EKG. That's more of in-hospital stuff. So long list of medications here. All the more reason to have some external resource handy for drug dosages for kids. But your main ones up top, lorazepam, diazepam, are going to be your two heavy hitters that you guys are using frequently. And then you've got your Keppra, Phosphene, all that kind of in your second line, secondary medication section there. And then third lines is more of your kind of down the line stuff that people are looking at in the hospital. But this is also where you kind of find yourself, having to establish an airway for continuous infusion of these kind of sedating medications. So that guy on the right is now on that pan to the left. This is the reason why I included that. Dog was interested. So respiratory failure. So why it matters. Respiratory failure is a common critical presentation. So bronchiolitis, asthma attacks, things like that. That's something we see all the time. Especially right now with flu, COVID, all that kind of stuff, RSV going around. We're seeing a lot of tough cases with flu. Upper airway obstructions. So we have croup, epiglottitis. Epiglottitis is a little bit more uncommon. I personally haven't seen a case of that, but see a lot of croup all the time. Lower airway disease such as asthma, and parenchymal diseases such as viral infections or pneumonia. Again, I like to stick with the pediatric assessment tool. And making sure we've got good O2 sats, making sure the kids are able to ventilate appropriately. So kids respond really well to high flow nasal cannula. A lot of times you can get good positive pressure just from high flow. But don't be afraid if you have the ability to do it to utilize CPAP or BiPAP for kids, because this helps them out from that standpoint a lot. Intubation indicated for apnea or persistent hypoxia despite maximal support. So this is kind of these are tough situations. These should be your last ditch effort. But most importantly, you're monitoring these kids, continuous pulse ox, end-tidal CO2 for ventilated patients, and make sure you're keeping a close eye on these kids if you are maintaining them during transport. So respiratory failure of lungs to maintain gas exchange, hypoxemic and hypercapnic. As we said, bronchiolitis, asthma, pneumonia, neuromuscular diseases, structural, ingestions, aspirations, things of that nature are things that you need to be looking out for. A lot of interventions that we can go from that standpoint, but from you guys, this is more of like typically a Duaneb or albuterol. And so just knowing your dosages and your protocols there. So since we're coming up on time, we'll kind of skip through the last couple of slides. I think there's only one or two more. Bottom line, what you're looking for is tachypnea or bradypnea, so breathing too fast or breathing too slow, retractions, stridor, grunting, nasal flaring, altered mental status, in an asthmatic, a silent chest. So all of these things can be signs of early respiratory failure. So intervening from that standpoint, from whether that's a nasal cannula, your non-rebreathers, or all the way up to high flow and BiPAP are astute interventions. So we go cardiac arrest. This is, we'll cover that here shortly in the skills station. A lot of stuff to go through there, which we'll talk through. We're right at 12, so I'll go ahead and pull the plug. But one thing I will cover, hit on, at least from this standpoint, we know the PALS algorithms and things like that. To get your certifications, you gotta meet the minimum requirement, and that is to know these dosages and medications. But one thing that I want to put on kind of at the forefront of this is establishing IO access early if IV is in any way or shape or form challenging. And then your defibrillation doses, your first shock, you can do it at 2 joules per kg, and then at 4 afterwards. So from that standpoint, those are two of the bigger changes that I want to make sure that we hit on: getting IO access and then knowing your your dosages from a medication standpoint and from a defibrillation standpoint. So key takeaways, working in the community, we're going to see kids, whether you like it or not, and whether you're ready for it or not. So preparation is key. Having simplified tools of assessment for kids, like the assessment tool, can help you sort through some sticky situations and cognitively offload, as can PD-Stat, Breslow tapes, calling children's, making sure that you have third-party resources available to help you make decisions. No one's going to praise you for being conservative, so giving a breathing treatment whenever you're not sure if it's indicated, putting oxygen on a patient when you're not sure if they actually need it, keeping those off of them isn't going to do you any good. So making the intervention from that standpoint, when it's a low-risk intervention, is never a bad one. Medication dosages are very different and very specific. It's all available to you, and you have resources where you can find these things, so don't be that guy and not have it handy. So a lot of stuff with kids, but the most important part I think to take from this is that they're very different from adults, right? And their medications, their various interventions, airway tools, all of those things are very different. So making sure you have the resources to help you make a decision in a very bad situation, I think is the most important thing. And I think recognizing the breadth of pediatrics and how much there is to it can help you be prepared for that moment when you got to take care of a sick kid. So there's a lot to it, a lot to cover. That was a lot of stuff, but hopefully you at least get a sense of what's out there and find some resources to kind of help you sort through those situations. See, the microphone's already going to the mouth, so I'm sure the chat's blowing up.
Hey, yeah, thanks for a great lecture, Dr. Sullivan. Pediatrics.
Oh, the dog? Yeah. I've taken care of him more than once. Yeah. I hope that dog's okay.
Taken care of the dog more than once?
I've shaken hands with the dog more than once, yes, actually.
So I'm assuming there's a patient that has a service dog that ends up.
He does.
I got you. Thanks for a great lecture. Pediatric topics are always real popular on Alabama EMS Challenge, and that's because pediatrics always make us nervous, right? So we had one kind of grouping of questions come in the chat, and they all were really about the same thing. One says, under blood products, it showed age-specific doses for packed red blood cells. What about plasma or for whole blood? On the dosing for atropine, it maxed at 0.5 milligrams. Shouldn't that be updated to 1 milligram since that's the current adult dose? So on and so forth. I think that a lot of this stems from we don't really do research on kids in the pre-hospital setting, so nothing ever gets updated. And because of ethical considerations, it's hard to get consent to the standards that's needed for research from a minor.
That was one of the strangest things I think that was said to me on my pediatric ICU rotation, but it also kind of gave me a sense of why we were doing things the way we were doing. So we would have a kid in septic shock from whatever reason in one room, and then in the next, they would both be on pressors, but they would both be escalated with different pressors and then de-escalated in different. So for example, like one kid would be on epi and levo, and we would scale back the levo before we'd scale back to epi. And then in the next room, he would be on levo and phenylephrine, and we would take the phenylephrine off before the levo. And we were rounding one day and we got past those two rooms, and I was like, why are we doing this the way that we're doing? Like, why don't you guys take away things in a stepwise fashion that we typically do? Like usually if we're on levo, epi, vaso, we're taking away the epi and then the vaso, and then, we wean off the levo. And the guy was like, we don't have, number one, like you said, we don't have the research, and we don't have these strict kind of randomized control trials in kids because it's not ethical. But two, he's like, we treat the physiology that's in front of us. And part of that didn't really make sense to me. But like you're saying, there's not necessarily set in stone guidelines a lot of times. And I admittedly probably did not update this all the way. I made a lot of this about 6 to 8 months ago, so I may have missed some updates if there are some. So forgive me from that standpoint.
I'm not aware of any updates, but I think it's all just behind. And the issue I was trying to get to is, we've got really good research and data, Berry et al., Grinnell et al., that all show that in adult cardiac arrest, we get much higher rate of positive patient outcomes by staying on the scene and working resuscitation and medical cardiac arrest. Yet, the areas that are embracing that are seeing big increases in their resuscitation rates. Yet on the pediatric population, it's still grab and run to the hospital. I think there's a lot of cultural reasons we do that, but do you see a time when we'll be spending more time on the scene and cardiac arrest resuscitation on those pediatric calls?
Probably. I think it'll turn out to be a lot like the adult cardiac arrest. I think as time goes on and more evidence comes out and they're able to because that's seemingly one of the primary ways that they get a lot of data is retrospective stuff. And as we go along, for example, like the whole blood situation with adults and the pre-hospital whole blood, like that stuff is on the forefront of adult pre-hospital care, but not so much on the pediatric pre-hospital care, just because there's more evidence for us. I think as things go along and we figure out what is best, and what I think will move the needle on that is having good pre-hospital pediatric care or good training so that we go out and make these differences. And then as the data kind of gets built over time, I think that we'll move in the same direction like that.
Yeah, I agree. That's also dependent on, on good documentation. Right? A lot of those retrospective studies, you don't realize your case is going to be studied 5 years or 10 years later. If you put garbage in your report just to get the report done, then it hurts everybody. So, yeah, good documentation with good care is probably the only real way we have to study pediatric training. Very good lecture. Anybody in the classroom have any questions for Dr. Sullivan? If not, we ran long today. Apologize for that. Not too bad. And if you haven't already, please take time to fill out an attendance certificate for today if you're listening online. If no one has anything else, we will see everybody next time. February 11th is the next meeting, and where's it going to be, Chief? We'll be at Helena Fire, February 11th. Everybody take care.